Bismillahirrahmanirrahim. Today we are going to discuss polycythemia vera. Last lecture we discussed chronic myeloid leukemia. Now this is another entity in myeloproliferative disorders, polycythemia vera or polycythemia rubra vera. Polycythemia vera is strongly associated with activating point mutations in the tyrosine kinase JAK2. So there is some point mutations. This results in more activation of the tyrosine kinase enzyme. And this typical tyrosine kinase enzyme involved here, there may be different tyrosine kinases. Now, the enzyme involved here, mostly this is JAK2. The most common JAK2 mutation sharply lowers the dependence of hematopoietic cells on growth factors for growth and survival. What is the result of this JAK2 mutation? The tyrosine kinases are more active, and now this will result in uncontrolled proliferation. Normally, this is under the control of growth factors. Now, after this mutation, these patients don't need these growth factors. What is the growth factor for production of red cell? That is erythropoietin. So, in these patients, we will see high erythroid production, high erythropoiesis or more active erythropoiesis in the presence of low erythropoietin levels in the serum. So this is typical finding in this disease. Because the proliferation is independent from this growth factor now after this mutation. So this mutation produces excessive proliferation of erythroid, granulocytic and megakaryocytic elements. All these are produced within the bone marrow, all these are more active, and we call this condition panmyelosis or panmyelosis. But most clinical signs and symptoms are related to an absolute increase in the red cell mass. So, increase in the red cell mass, this is more important, and this produces some clinical symptoms. Now, what are the clinical features in these patients? The disease occurs insidiously, usually in late middle age. Patients are plethoric and often somewhat cyanotic. I will show you some picture to explain what is a plethoric facies, reddish, bluish red color of the face. Histamine released from the neoplastic basophils may contribute to pruritus, and in these patients, due to increased histamine release, we can see increased tendency for peptic ulceration. Because this mutation, this involves all these series in the bone marrow. Myeloid series are also produced more. So there is also basophilia. Basophil will release the histamine, and this will produce some clinical problem like pruritus and more tendency for peptic ulceration. Other complaints are referable to the thrombotic and hemorrhagic tendencies and to hypertension. So red cell mass is more, red cell count is very high, hematocrit very high, plasma is relatively less. So there is thrombotic tendency in these patients. So So patient also usually have hypertension. So many complications due to this hyperviscosity or prothrombotic fail. Headache, dizziness, gastrointestinal symptoms. So these are common, and we can see hematomesis and melena. Hematomesis, bleeding from the stomach. Patient will vomit blood. Melena in the lower portion of the intestine, when there is bleeding within the intestine, this will mix with the stools and patient is passing black stools. The degradation products, and these stools will mix with the blood, and this changes the color of the stools. So this is black stool. This is known as melena. Patient will complain, oh, kale pakhane aate hain. Gout is common. Another problem due to high cell turnover, more production of red cell, white cell, all these glucoses are more active. So there is high turnover, more production of urine and pyrimidine. So this results in high uric acid, and this will result in gout-like symptoms. In morphology, we can discuss these points. Major anatomic changes are due to increases in the blood volume and viscosity. Blood volume is increased. This blood is more viscous due to high red cell mass, high red cell count. Congestion of many tissues is characteristic. So many tissues are receiving more blood, so that is why we see plethoric face, reddish color of the face. Liver and spleen enlarge due to extramedullary hematopoiesis. So maybe a bit late stage of the disease. There is fibrosis in the bone marrow, and the organs which were producing the hematopoietic elements in the intrauterine life, they can become active. So hematopoietic elements like erythroid precursors, myeloid precursors, these are also being produced in the liver and spleen. This is known as extramedullary hematopoiesis. So when this occurs, so there will be enlargement of the liver and spleen. Thrombosis and infarction. The blood is more viscous, so we can see the clinical features of hyperviscosity syndrome. Due to both viscous blood, there is a tendency for thrombosis. When there is thrombosis, this can result in attacks of infarction, and we can see these attacks in different body organs like in heart, spleen, and kidneys. In these patients, although platelet count may be high, above normal, but still we can see a bleeding tendency. These hemorrhages, these are due to functional platelet defects. The platelets, neoplastic proliferation platelets, these are not functionally normal, so they are not performing their proper function. Patient has a bleeding tendency. Due to this, we can see some bleeding in GIT, in the brain, or in the oropharynx. So what we will see in routine blood CBC, typical findings are hemoglobin will be very high, RBC count is high, so we can see a peripheral smear, TLC is high, RBC count is high, hemoglobin is high, PCV, all these are maybe very high. On the peripheral blood smear, we can see more prominent basophils, basophilia, high platelet count. So all these findings we can see in a routine blood examination, CBC and peripheral blood smear examination, what we do routinely for hematological evaluations. If we aspirate the marrow, bone marrow is hypercellular due to hyperactive erythropoiesis, all these things. This is understood. The tyrosine kinase results in increased activity of all these elements in the bone marrow. We have discussed pan-myelosis. Erythropoiesis is more active, myelopoiesis is more active, megakaryopoiesis will be more active. So bone marrow is hypercellular due to hyperactive erythropoiesis, myelopoiesis and megakaryopoiesis. We call this pan-myelosis or pan-myelosis. When these are more active, what will be the results? The fat spaces in the bone marrow will be reduced. Most of the bone marrow will be showing the active hematopoiesis going on. But in the late stage of the disease, in an advanced disease, there is more activation of fibroblasts. So bone marrow, this gets more and more fibrosis. This is fibrotic. This is known as a spent phase. In the initial stages of the disease, bone marrow is more active, fat spaces will be reduced, all hematopoietic elements are produced in excessive amounts, but in late stages there will be more activity of the fibroblast and bone marrow will get more fibrosis. This is like idiopathic myelofibrosis. This is known as spent phase. This is complication of this disease. Diagnosis, how we will diagnose these patients? Diagnosis is usually in the labs, although sometimes the face of these patients is also very clear, plethoric faces. We can see the patient and we can say, oh, most probably this is the case of polycythemia. When we do routine blood examination, RBC count may be 6 to 10 million per microliter, hematocrit maybe more than 60%, hematocrit or PCV, packed cell volume, they are same. If we say PCV, this will be more than 0.6 liter per liter. Same we can say hematocrit 60% or more than this. That means plasma is less as compared to the red cells. TLC may be as high as 50,000 per microliter. Platelet count usually more than 400,000. This is upper normal count. So usually platelet count may be above normal. Platelets are functionally abnormal and giant platelets and megakaryocyte fragments may be seen on the peripheral smear. What is a giant platelet? Platelets are much larger in size, almost approaching the size of a red cell. These are giant platelets. Megakaryocyte fragment, normally megakaryocytes are present only in the bone marrow. Very rare conditions when these will come in the peripheral blood. Only fragments of the cytoplasm of the megakaryocyte, this come in the peripheral blood. These are the platelets. But in these patients, megakaryopoiesis is more active, so some of the Megakaryocytes are fragments of the megakaryocytes, including the nuclei. They may come in the peripheral blood, and we can see these small megakaryocytes on the peripheral blood smear. So we have to differentiate this condition from other causes of erythrocytosis. I will give you some table other causes. What are the other causes of erythrocytosis? Now this is mainly from your book. This is just to clarify some things. If some of you can memorize these things, okay, this is from essential hematology. Otherwise, not necessary to memorize these things. Genetic mutations in myeloproliferative disease and other myeloid neoplasm. What is the genetic mutation in chronic myeloid leukemia? ABL1. Polycythemia vera, JAK2. Primary myelofibrosis, maybe JAK2 or CALR, maybe MPL. Different mutations. Similarly, essential thrombocythemia, JAK2, CALR, MPL. So all these are included as myeloproliferative disorders. So in polycythemia vera, primary myelofibrosis, essential thrombocythemia, main mutation is JAK2 mutations. Mastocytosis, myeloid neoplasm with eosinophil, these are not in your book, so no need to memorize this. So this is a diagram just to show you, to clarify what we have discussed, same thing. You can see bone marrow stem cell, there is some acquired abnormality. This mutation can result in change in the erythroid series, red cell precursors. In this case, the main mutation is in the JAK2. Maybe 97% of the, in most of these patients, they have JAK2 mutations. And what is the clinical entity? This is polycythemia rubra vera, polycythemia vera, what we have been discussed now. Now, almost 30% of these patients, you can see this, these can, in the late stage of the disease, these can go to the spent phase. That means more fibrosis in the bone marrow, and condition is resembling like picture in primary or idiopathic myelofibrosis. A small subset of these patients, 5% of these patients, can go to picture like blast crisis, and this can change to acute myeloid leukemia. Now, in another step, there may be some mutation that can result in overactivity of the megakaryocytes. The mutated gene, this is again JAK2 in 50 to 60% of the cases. In polycythemia vera, this JAK2 mutation is was present in 97% of the cases. Here, in essential thrombocythemia, JAK2 mutation may be seen in 50 to 60% of the cases. Other cases may be CALR mutation in 30% of the cases, and this will result in excessive production of platelet. This is essential thrombocythemia. 10 to 20% of these cases can again go for a spent phase, and picture will be resembling to idiopathic myelofibrosis. Sometimes this mutation can result in a reactive fibrosis in the bone marrow. This will result in idiopathic myelofibrosis, right side. Again, we can see in 50 to 60% of the cases there is JAK2 mutation, and the remaining 30% of the cases we can see CALR mutation. So there is more activity of the fibroblast, more deposition of fibroblasts, and this will result in primary myelofibrosis or idiopathic myelofibrosis. We can see this fibrosis in some precious reticulin stains in defined biopsy. In idiopathic myelofibrosis, almost 10% of these patients, again, these can go for transformation to acute myeloid leukemia. So, these are interrelated diseases. Now, this is the table. What are the causes of polycythemia or erythrocytosis? Primary erythrocytosis, this may be congenital or acquired. Secondary erythrocytosis, again, congenital or acquired conditions, so many. If you can memorize some of these, but just you should know these. There may be so many conditions where we can see any high hemoglobin level. We must differentiate this from different polycythemia vera. Radiodilation methods for measuring red cell and plasma volume. So, to pinpoint for the pinpoint diagnosis, we need these tests, maybe a bit advanced setups. We can measure the red cell volume, we can measure the plasma volume. So, red cell volume is increased in polycythemia vera. This will be normal in relative polycythemia. Total plasma volume will be normal in polycythemia. This may be decreased in the relative polycythemia. Now, this is a patient, polycythemia vera, facial plethora and conjunctival suffusion in a 63-year-old woman. Now, you can see the face. So, if we see this patient, just from the face you can assess. So, most probably this is suffering from polycythemia vera. So, in this case, hemoglobin about 180 gram per liter and 18 gram per deciliter, and red cell volume of 45 ml per, all these are increased. Now, what are the clinical features in these patients? So, the disease occurs insidiously, usually in late. Here you can see the feet of a 72-year-old man with polycythemia rubra vera. There is inflammation of the right metatarsophalangeal and other joints caused by uric acid deposits. So, there is high turnover occurring the pyrimidine, white cells are extract. So, there is results in high uric acid. These uric acid crystals are deposited in different body organs, and this will result in gout-like complaints. In picture B, you can see the gangrene of the left fourth toe in essential thrombus. Now, this is a picture just to show you iliac crest fine biopsy. In A, you can see polycythemia vera. Fat spaces are almost completely replaced by hyperplastic hematopoietic tissue. All hematopoietic cell lines are increased with megakaryocytes particularly prominent. These bigger cells in this picture you see, these are the megakaryocytes. Whitish spots in the marrow, these are the fat cells. I have shown you this picture, almost 50% is occupied by these fat cells, but these are absent in this picture. So, this B, this is for primary fibrosis, myelofibrosis, idiopathic myelofibrosis. We will discuss this next. Thank you.